The U.S. has declared monkeypox a public health emergency with more than 7,000 confirmed cases now across the country. The number of positive cases doubling about every 8 days since May, and a major shortage of vaccines and lackluster testing. And the virus is spreading beyond men who have sex with other men. Several cases in women and children have also been reported. Joining me now is President Biden's chief medical advisor, Dr. Anthony Fauci, director of the National Institutes of Allergy and Infectious Diseases. Dr. Fauci, so good to see you again. Thank you. Thanks for coming.
My pleasure. Good to be with you.
So what does declaring this a public health emergency do in practical terms? Will that make more vaccines available?
Yeah, well, there are practical considerations, Andrea, and there are symbolic considerations. The practical considerations are that when you declare a state of a public health emergency, a lot of the bureaucratic and logistic issues that are good in a place of non-emergent situations, they are allowed to be bypassed. For example, things that might take several days to get through, paperwork, bureaucratic things, they get pushed aside, not recklessly, but enough to expedite things in a manner to get things done much more expeditiously. I mean, there are many examples of that. Things that, for example, you'd have to wait a week to get put through the system, you can do very, very quickly. Some of the things that we do here at NIH in the granting and contracting process, that you can bypass some of the things that would be standard because of the emergent nature of it. But as important as that, Andrea, is the symbolic aspect of it, to really show the community and everybody else that all hands are on deck right now and everybody's on alert that this is a very, very high priority issue. So just the idea of declaring it emergency goes a long way to make sure that people understand that this is a very high priority.
You experienced, firsthand in your role at the NIH, the stigmatization of the gay and bisexual community, the male community, during HIV/AIDS, and how you dealt with it and became really a hero in your response. How do we avoid that this time?
Well, we do exactly what we did when we got it right, finally, back then. You have to engage the community, and you've got to put yourself in their shoes and say, how can we make it such that there is no stigma, or at least a very strong alleviation of any potential for stigma, at the same time that you provide directly to the community the services that they need. And that's ample accessibility to testing, therapy without any stumbling blocks of unnecessary paperwork and bureaucratic hoops that one has to go through, and enough vaccine not only to get people protected in a post-exposure prophylaxis, but in a pre-exposure prophylaxis for people who are clearly at risk, even though they have not had a documented exposure. The way you do that, and do it expeditiously, is to make sure you engage the community at every single step. Top down to the community doesn't work. That's the lesson we learned from HIV. You embrace the community and get them involved in all the processes you have to do. When you do that, you dramatically diminish the possibility of stigma. There will always be stigma in our society, but you've got to minimize it very much to the extent that you can.
Can you explain how big a deal it is that the FDA commissioner has now approved injections subcutaneously? Does that stretch the amount of vaccine that we have available?
Yes. I mean, I'm not sure it was yet a final decision on that, but they are certainly moving very strongly in that direction. And what it is that there were studies that were done by my institute, actually, years ago and published in the literature in 2015, which showed that if you take that same vaccine, that JYNNEOS vaccine, and compare a subcutaneous injection with an intradermal, which means that you inject it very carefully into the layer of the skin as opposed to underneath the skin, you can get a comparable response with 1/5 of the dose. So if we can get that going, and I'm leaving that up to the FDA to be able to get that approved to go through that and to authorize it, that would save 5 times the doses. In other words, you could take what would be the equivalent of 1 dose and make that equivalent now to 5 doses with the same effect on protection.
Did the U.S. miss the boat in, making sure that we had enough vaccine on this by focusing on other things?
No, I don't think so, Andrea. I mean, obviously, you always could have done better in getting vaccines mobilized and ready to go more quickly than it was. But if you look at what actually happened, if you look at the vaccines that were given to the states of what they had asked for, it was generally under the umbrella of post-exposure prophylaxis. But it became very clear quickly that you needed it for pre-exposure prophylaxis also. So right now, there have been about 600,000 vaccines deployed. We will soon have 1.1 million. Would we have liked to have done it more quickly? Of course, you can always do better. But right now, looking forward, we've got to concentrate all our efforts to make sure that everyone who's at risk of getting infected with monkeypox has the ability and accessibility to get a vaccine to protect them before the fact.
Are you concerned that it is going to spread beyond that community, especially with school about to reopen, people traveling so much? Can it be passed along in other ways?
Yes, it can. We already know that. You've already shown the headlines on some of the news clips that you just showed, that women can get infected and children can get infected, because although in the sexual setting of intimate contact in a sexual situation, particularly among men who have sex with men, in fact, the close skin-to-skin contact is the modality of transmissibility. There are other ways of skin-to-skin contact that not necessarily in the sexual context. And also, for example, what we call fomites or inanimate objects, blankets, towels, and things like that. Now, we have not seen to any substantial degree that kind of spread beyond some individual examples. That does not mean we're going to not see more of it. So rather than panic about it, we just make sure we pay close attention and take it seriously. I hope we don't see any more to a substantial degree of spread beyond what we're seeing, but it's entirely possible that we will. And that's the reason why we've got to be prepared for it.
I know we don't have much more time, but briefly on the BA.5 variant and the booster we're hoping for in September, is it going to be outdated by the time we get it?
Well, we never know what we're going to see with COVID. I mean, history has taught us that. We are at the peak now of a BA.5, which is the dominant isolate in our society and actually throughout the world. Will that be dominant when we get to the fall? Likely it still will be a challenge. Will something come else and take its place? We don't know that, Andrea, but we've got to do with what we have. And it's very likely, if it's a variant of BA.5, that the bivalent booster that we're talking about will have at least some degree of coverage, very likely against severe disease, which is what we worry about the most. But these things are unpredictable, and the only thing one can do is to do the best as we can. And the best anticipation is that a BA.5 bivalent is about as close as we can get based on what we know right now.